Good morning, everybody, and welcome. That was a lot of information to take in, and we're going to dive a little deeper on some of those with this panel. As Dr. Coe said, I'm Gretchen Michael. I'm the Director of Communications for the Administration for Strategic Preparedness and Response, and I'd like to talk a little bit about this panel. We're going to explore the strategies and actions that have been or could be implemented in the institutional and structural levels. Interventions at this level may include things like setting standards for journalists, fact-checking, regulating social media, or setting policy or legislation. I think a number of these things were touched on in Tara's paper. They could also include preparing and disseminating resources for journalists, researchers, and infodemic managers, toolkits. To dive right in, we've got a panel here representing a range of experiences, and I'm going to invite each speaker to share their remarks and some of their background, and each has 5 minutes. I want to emphasize 5 minutes to speak, and then we'll have a question and answer period. If you'd like any more information about the panelists, a link to their bios has been posted on the event webpage. And then we're also asked that if you have questions for the panelists, please put it in the Q&A window beneath the video player. So our first speaker, I'll just quickly go through. We've got Sue Curry from the University of Iowa College of Public Health, Tricia Corrin from the Public Health Agency of Canada, and Phil Maytubby from the Oklahoma City County Health Department. So why don't we start with Sue? It's all yours, Sue. Go ahead. You're on mute, Sue.
There we go. Okay. I just thanked everybody for the invitation. So my brief remarks, I'm going to be representing work that's been done by 2 advisory committees that have been focused on defining principles and attributes of credible sources of health information. Disclosed that there was administrative support for these advisory committees from YouTube. And the premise is that an increasing proportion of the population rely on social media and the internet for health information. And clearly, as you know from what's already happened, there are issues with health misinformation and its effect on the health of the public. Our work focused on one piece of this very complex puzzle, health information sources. And across 2 advisory committees, we looked at principles and attributes of credible sources of health information across the spectrum, from government sites, accredited institutions, nonprofit organizations, for-profit organizations, and individuals. So 5 minutes is not sufficient to go into detail about the work, so I'm just going to make 2 points, and we can bring up the first slide. On the first slide, which we can leave up for the next couple of minutes, it summarizes the principles and the descriptive attributes that the advisory committee proposed. And in brief, as you can see, the principles are that credible sources be science-based, so they're providing information consistent with the best scientific evidence. They're objective, the sources take steps to reduce the influence of financial and other forms of conflict of interest or bias that could compromise the quality of the information. They're transparent and accountable. They disclose the limitations of the information they provide, as well as any conflicts of interest, content errors, or procedural missteps. And they're inclusive and equitable. And this principle was added by the second advisory committee. They prioritize inclusion of diverse, equitable, and trusted voices for health information that reflect the demographics of the audience. The attributes, which I'm not going to read, are indicators of adhering to these principles. And the consensus on the committees was that sources should meet a preponderance of the attributes, but they don't have to meet all of them, nor did the committee recommend any kind of numerical scoring approach, et cetera. Many of these attributes can be self-disclosed by health information sources. Others could be obtained by AI algorithms and so forth. My second point, and we can go to the second slide, is that identifying credible sources is important, but it's not sufficient, obviously. Social media platforms need to invest in content assessment. There are questions about that. We've thought about mechanisms for that. Sources need to be transparent and consistent in their strategies to manage misinformation. It's one thing to identify credible sources, but that does not focus on what do you do with misinformation. And as noted in the principles and attributes that I just mentioned, paying attention to audience is critically important, including considerations of health literacy, cultural competence, and building trust. And finally, social media platforms need to commit to rigorous evaluation of the strategies they adopt, particularly through transparent partnerships with researchers. So I'm going to stop my remarks there and let you move on to the next speaker.
Thank you, Sue. I look forward to hearing what kind of questions folks have based on your presentation. Next speaker is going to be Tricia Corrin from the Public Health Agency of Canada. Tricia?
Good morning, everybody. So as Gretchen said, my name is Tricia Corrin. I'm an epidemiologist with the Public Health Agency of Canada. And specifically, I work on a knowledge synthesis team. So we specialize in knowledge synthesis methodologies for infectious diseases. So today I'm going to talk about our COVID-19 literature surveillance framework that we developed and maintained throughout the pandemic. So as we learned through the Zika epidemic, we knew that at the beginning of the pandemic, the literature about COVID-19 was going to come in fast and furious, and we needed a way to collect and organize it all. So using established knowledge synthesis methodologies, we developed and maintained this literature surveillance system to identify, characterize, and disseminate COVID-19 evidence on a daily basis. So this was initiated back in January of 2020. So essentially, I'll run through the methods very quickly, but our team would search the evidence. So search the preprints and published literatures, get rid of duplicates, and import this into our systematic review software called Distiller. And within this software, we trained some AI tools to do a bit of categorization for us, such as differentiating between synthesis research, non-primary, and primary research. From there, we had a team of reviewers who looked at each article to pull out some of the key information and tag it so we could search this database very easily moving forward. From there, we essentially gathered all the evidence daily, put it into an email, highlighted the key research that we thought people would want to know about, and sent this email out daily. In addition, there was a link to a fully searchable repository of information that people could search themselves as well. So this email was sent over to about 200 recipients every day, and this spanned people from federal and provincial governments, local public health agencies, as well as academic institutions. And just to talk briefly about why this was important. So as we've learned about this epidemic, there was so much information coming out and people didn't have the time to search it themselves. So I wanted to highlight how this database was used. So to start, teams such as ours, evidence synthesis teams, use this database to quickly conduct rapid syntheses on priority questions. So having this database available made the work a little bit less redundant, so people didn't have to go back in and search. So we were able to produce 150 rapid reviews on priority topics using this database. Across the agency, other groups used our database to do things such as stay on top of the most up-to-date evidence coming out about COVID, report highlights to senior management, populate predictive models. We have a lot of modeling teams throughout the agency, and do things like create guidelines and web content. So just fast forwarding a little bit to Mpox. So unfortunately, there wasn't much of a gap between the Mpox pandemic and COVID-19. So we also produced a similar surveillance system for Mpox. But one thing we did a bit differently was that we created a living evidence review on all this information coming out about Mpox. One thing to note was that we had a great collaboration with the WHO, who were also looking to do something similar, but instead of duplicating their efforts, they were able to use our living review to basically, sorry, look at my notes here. Instead of replicating their work, they were able to use our work to inform their own work to extract epidemiological parameters from the emerging literature. So we collaborated together to make sure there was no duplication and ensure that we were extracting and reporting key information that was useful for both agencies. So I know I glossed over the methods really quickly, but I just wanted to talk a bit about moving forward because these literature surveillance systems are very important to keep on top of the most important and emerging evidence coming out rapidly. So we're currently in the process of conducting a hot wash on what worked and what didn't for both the COVID-19 and Mpox literature surveillance systems so that we can be prepared for the next public health emergency. So in addition to just documenting what worked and what did not work, we have a lot of ideas on how we can improve the framework for literature surveillance systems moving forward. So for example, we want to utilize more AI tools because these systems required a lot of people power on some of the processes. We also envision creating a dashboard as an example so people can publicly search this database themselves instead of relying on a daily email. So there's a lot of manpower, people power things that we think that we can improve through AI tools and things such as dashboards. My last note before I let the next speaker talk was that as we saw throughout the pandemic, we started to see a lot of duplication. So many groups such as ours created these repositories of COVID-19 literature, Mpox literature. So we really would like to see more collaborations and communications such as the collaboration we have with the WHO moving forward. So we can hopefully utilize the expertise of each other and create some of these huge structural interventions that hopefully more organizations can use, and we can reduce the duplication a little bit. So that's it for me, and I hope that we can have a fruitful discussion about this.
Yeah, I think there'll be some interesting questions to talk about how your database was used and how it can support information sharing and across a broad spectrum of audiences. So look forward to that. Okay, our next speaker is Phil Maytubby, who is with the Oklahoma City County Health Department. And he is going to talk a little bit about what he did on the ground to share information with his community and what was successful and what he continues to do.
Hey, again, thanks for allowing me to participate in this workshop. So I wanted to start with one of the reasons, some of the things that we do, we sometimes create the opportunities for mistrust because we don't know how the public is perceiving our message. So I want to talk to you guys about some of the analytics and things that are available out there that you can utilize to really help. I know on our vaccination campaign that we had to do some changing midstream because of some issues with wording, and it changed approximately 10% of our population's view on how the message was perceived. So first slide, please. So this is called sentiment analysis. So if you guys aren't using this, you probably will want to look at this. This is how the wording in your messaging is being perceived by the general public. This goes across all data streams, whether it's social, mainstream media, radio. And as you can see here, you look here at the words that are down there that are big: COVID, vaccine, vaccinated. Those were being perceived very, very negatively. So we had to change a vaccine campaign. We changed it to the word choose, which was basically, we're going to provide you the information and you choose, because, you know, people don't like to be told what to do. They like to be provided with information and make the choice, especially here in Oklahoma. I mean, we're a purple city in a red state, and it is difficult at best to do messaging sometimes. So next slide, please. So this is some surveying that we actually did that really shows, I mean, this is like a game plan for how to message, when to message, what to message. It goes down to demographics, age ranges, and things like that. You guys all know that people get their information primarily from their phone, but from different sources, whether that's a website or social media. And, you know, there are many different platforms, and most of these age demographics have a preferential one. So you end up having to shape your messages based on the demographic that you're using. So this has been very, very valuable for us because it really has changed how the people perceive us here. And it's giving us better trust because everybody knows it's all about trust. You can see some of the relevant numbers down here about the percentage of people who changed their view. This was surveying we did after we changed from vaccinate to choose. So when you can affect the viewpoints of about 80 or 85,000 people in your campaign, that's a big deal. So anyway, you can look at those. There's some really, really good information. You could dig in this for a long time. Next slide, please. So this is pretty much how the public perceives their information here. As you can see on official channels, there's not that much. So people aren't really basing their decision-making on mainstream media. They're really using social media as their object of choice. And this is for our Oklahoma City market. As you can see, we get a lot of activity through Facebook. There's a lot of different things we use Twitter quite a bit. And then we have all these different channels. So not only does this tell you how people are perceiving your message, but it tells you where they're getting their message. So at times, we've had to boost messaging, and if you guys are in this game, you know what that means. Like if you're boosting things on your social media channels, and it makes a huge difference. And sometimes it's very low cost. So these are some of the methodologies that we have used here. So I hope this is valuable for you folks, because one of the lessons that we have here is, as public health or health in general, we have to spin up our game. We have to use analytics. We have to try to become effective messengers, because if we don't, we're just not going to be effective, and we're just not going to do what we need to do. So I guess that's it for me for now. Thank you.
Thank you, Phil. So I have a question about your presentation. So were you doing these surveys in real time? Like, how long were your messages out in the field, your vaccination messages out in the field, and what was the sort of delay in terms of surveying? And I'm assuming you used outside groups to do that.
We did. We used a contractor. So basically, the messages had already both run their course, the original campaign and the updated campaign. We waited for it to close before we did the survey. So, that was about a 2-month change. But as you can see, it was highly effective to see what we had done.
Yeah, no, it's interesting, and it's great that you guys were able to pivot and change your message so that it was your messaging ultimately was more effective and was more well received. I'm wondering if there's if you know of colleagues across the country who did similar surveys and message adaptation along the way.
I know that some of the big cities did.
Mm-hmm.
And I know a lot of them are also using some of the analytics materials that are contractors that we are using, because they're widely available. I just don't know how you can actually do this anymore without having this kind of information.
No, it makes complete sense. It would be interesting to talk to NACCHO and others about, pulling together what, sort of a spectrum of what was done around the country, and if the feedback was different in different parts of the country as well. So I'm going to throw this out to the group in general. I guess maybe for Sue or for Tricia, what additional research or evaluation is needed to fill the knowledge gaps, some of the knowledge gaps that we've heard about over the last day and then this morning?
Well, I'll take a quick stab at that. So I think from our perspective, it's really in this domain evaluation research, that if a social media platform like YouTube, which did implement some changes based on these recommendations, initiates those, you need to really rigorously look at, does it make a difference? Or is it public relations? So I think that's very important information. Clearly, the content analysis piece is complex, and partnering with experts in communication and content analysis, of which I am not, would be another place where we could do more research. But I am going to put a marker down and say that oftentimes in academics, we spend too much time thinking about what we don't know, and we don't fill the gap between what we know and what we can do. And so I do think research is important, don't get me wrong, but I'm more inclined to be focused on, let's get into practice things that we know that we can do and then evaluate them. I love my colleague from Oklahoma, where you're in real time looking at what's happening and you're able to make adjustments. And there are some very tried and true research methodologies, multiple baseline studies and so forth that could be tacked on to these efforts that would give you perhaps, a more generalizable, although this is generalizable, so I want to be careful what I say, a peer reviewable paper on how this worked and what happened.
Thank you. Tricia, anything to add?
I guess one of the things I would say is learning about all these misinformation, like databases and stuff, would be interesting to see if we could somehow incorporate into our database, because we're trying to strip our database of things like editorials and commentaries and keep with primary research, but there's a lot of manual process that goes into some of our database, like for example, when something's retracted. So it isn't until we find out it's retracted where we have to manually take it out of our database. Same thing with preprints as well, going from preprints to published. That's a very manual process. So I look forward to seeing if we can somehow get some of these AI tools to help us with some of that work in the future, and maybe somehow working with misinformation databases to see if there's anything in our database that shouldn't be. So I do envision some collaboration and some work that could be done in order to make some of these tools more effective.
This one is probably mostly directed to Phil, but based on your experiences, and you touched on this, what actions and plans and strategies would you put in place or recommend that your colleagues in public health, both state and local, put into place before the next public health emergency?
Well, I think it's just a kind of a rehash of what I just put in there. We need to do this on a regular basis, not just when we have emergency issues going on. We need to be constantly looking how the public is perceiving us, whether that's through surveying or through doing the sentiment surveying or other things that you can get through analytics. So that needs to be actually part of your communications process.
And the other thing too is, you're hearing, having heard all of this over the last day or so, the various elements. I mean, how do we create an enterprise of all of this stuff? I mean, we're not there yet. There's all these different projects going on at all these different levels, at the academic, at the work that you're doing, the direct community contact. But I think ultimately that is where we need to go, is we need to create an enterprise-wide system of communications for public health and how we communicate with the public about health information. So I guess the question is does the work that you did, Phil, in terms of sentiment, or for anybody, for Tricia as well, the work that you've done, does it apply for things beyond public health emergencies, and pandemics, or can it be used sort of day to day?
I would say most definitely yes. Because, we have different messages that are going out about different things that are more like everyday public health all the time. And I think it's very important that we know how the public is always perceiving what we're saying. Because, just a slight change in words or when you put things out or how you put them out can make a huge difference in your overall reach to the community.
Have you made any shifts in your day-to-day public health messaging based on lessons learned from COVID and what you learned?
We have. There for a while, we were getting so much feedback, negative feedback from what we were trying to put out, just by trying to put out facts, that for a while, it was better for us to just kind of let it calm down. And we did that for about 2 weeks, and guess what? It died off. So now we're kind of back to square one when it comes to our communicational methodology.
So we touched a little bit on institutional interventions implemented by social media at the federal, national level, and local level. How should all of these partners and players interact? And maybe that's a question for you, Sue. You're on mute.
Nothing substantive. So I'm going to give an analogy, and I'm going to say social media companies have resources. They have a lot of resources. And one of the things that we talked about on our advisory committee, and this was around content verification, so trying to get rid of misinformation, is the Belmont report, which came out a number of years ago around protection of human subjects in research. It's a set of principles and attributes, and it's operationalized by partnerships and by resources that are invested by academic institutions at this point to create institutional review boards and so on and so forth. Now, the academics out there who are probably, having spilkies like, no, not another thing like that. But I think that it's really important to think about how people with a stake in this, a financial stake, as well as a good citizen, an ethics stake, invest in creating the kind of infrastructure that could allow, health departments, the work in Toronto, the work in Canada, the work in Oklahoma, to have access to a network of, well-funded reviews or infrastructure to help ensure that the content that you're releasing is not only factual, but it's also audience friendly. So I'm going to give a very quick example. I wanted to test the YouTube notation of credible sources. And so I went into YouTube and I did a search for ivermectin. The first thing that came up was a credible source, and it was a 45-minute academic videotape about ivermectin. The second thing that came up was Joe Rogan. Where am I going to go? So that's, I watch a 45-minute video. I'm going to go to somebody who's going to entertain me and so forth. So my point being, we have a long way to go, both in the content and the presentation. And I think that there are paradigms out there that could be adaptable that would allow us to do that.
Thank you. I am not seeing any more questions. Oh, wait, we have one more question to Tricia. How did you handle reviewing and sifting through all of the preprint articles? And did they have quality inclusion or exclusion criteria for what made it into the database?
That's a great question. So as for our database, we did not have any inclusion or exclusion criteria as long as it was primary research. But we did find the process of dealing with preprints very difficult. I'm doing a little bit of research on the side as well, pertaining to knowledge synthesis practices during a pandemic. And it seems to be an overall theme that lots of groups didn't know how to handle these preprints because oftentimes the title would change. So when you're doing a duplication search, you don't find them, or the authors have changed, or they've published it in 2 different journals. So there's a lot of issues we just had that this became a very manual process for us to try to find the published version when it came out, as opposed to just making sure we had the right one in our database. So there probably is a lot of duplication in our, shouldn't say a lot, but we try to manually get rid of them. But that was a huge problem, and there doesn't seem to be any solutions for this, or I haven't met anybody who has a solution for this. So if somebody does, I would love to hear it. But one thing I just want to talk about a little bit further was, so yes, our database doesn't have any exclusion criteria on what we include in terms of preprints, but when we actually do our rapid reviews on a specific priority topic, we definitely use like risk of bias tools, even though they're done at a very high level, to kind of pinpoint good research and bad research. So our database doesn't have that, but when we actually look through the database to do these rapid syntheses, we are definitely looking at quality of evidence. I hope that answers your question.
Yep. So we have a comment talking about sentiment and how one caution about how tools classify sentiment and emotion in terms of social media messages, that they're very unreliable for controversial topics. For one thing, they don't get sarcasm. And I also know that, and maybe they're better, but I know words like emergency tends to have a negative, be perceived as a negative when in fact it's not. Another question we have is how do we get survey capacity like what is seen in Oklahoma City into every state and local health department? What would it take and how much would it cost? I think that's for Phil.
I can answer some of that. So we basically hired a contractor. It's probably not as much as you would think. You know, you just want to make sure that they, whenever they're doing their surveying, that they put it out in an unbiased, methodology that truly picks up the sentiment. But yeah, it's widely available. I mean, we can do it locally. I mean, here with our own staff, but doesn't seem to be as effective. It needs to come from a neutral source.
And I just wonder, what do you all had the funding, obviously, outside of any kind of additional COVID funding that you may have received, would you have been in a position to do that day to day?
Probably not to the extent that it was done, but we do it on a regular basis. We actually do a lot of surveying. So yes, it is possible, but for you to do a robust thing like that, you would probably need to staff up.
And well, that leads me to the next question. So who did the work from your team? I know you said you had a contractor, but was it the comms team or who led this at the local health department? Who led this initiative?
It was a team effort between our executive leadership, our epidemiology team, and our comms. Okay. So it really takes, I'll tell you what, if your comms are not being informed by the executive level right now, you're going to get yourself in trouble. Especially with COVID, it was an executive level issue. And that's where all the pressure was. It wasn't at the staff level.
I'll ask the same question to Tricia. The work that you did, the research and the databases, who owned that at Public Health Agency Canada?
Sorry, what was the end of your question?
Who led that effort at your agency?
So it was actually our team, the knowledge synthesis team within the National Microbiology Laboratory, which is part of the Public Health Agency of Canada.
So is it the sort of the information management group or data analytics group or?
No, it was us. So we're a knowledge synthesis team.
Okay.
So outside of the pandemic, we produced systematic reviews on all different types of infectious diseases. So one thing I should note, though, we led this project because we have the methodology expertise on our team, but it required a lot of people power, as I said. So people manually going in and looking at these articles, tagging them by the different foci so the database could be easily searched. So we ended up recruiting probably 30 to 50 people from across the agency with all different types of scientific expertise to help out with this project. So through the duration of it, we had a lot of people across the agency helping because, as I mentioned, people from all over the agency were using our database. I shouldn't say still are. So we're still maintaining this database for both COVID-19 and Mpox now.
And this was, your database was accessible not only at the federal level, but also at the provincial level as well?
Yes, so it's actually available to the public as well. So We wrote a methods paper. If anyone wanted more details on what we did, but within the supplementary information, there's a link to our database, so anybody can search it. So you can be government, academic, member of the public. It is fully searchable. So I'm happy to provide that link to anybody if anyone wants to reach out. But yes, it is available for anyone to use. And hopefully, like I said, I hope we can make this user-friendly in the future. More user-friendly, I should say.
So how do we, who talked about that? I think Sue, you mentioned this. You're still there. Let's see, Sue. If you're still there, I think you mentioned about providing timely information and letting folks know when information, new information would be available. So I throw out the question, how do you manage evolving situations when the evidence is changing and updating so quickly? I mean, you know, one of the things I recall from H1N1 back in 2009 was there was the CDC did an excellent job of prepping the public for the fact that information was going to change. You know, that the information, here's what we know now. Here's, you know, it may change. We're learning every day. How do we do that? How did you manage that, Phil, given the changing environment? And how do you do that in an environment where, you know, there may be folks saying, well, you know, you were wrong. You know, you look at kind of how things were spun by certain elements that basically said that, you know, if you change your mind or you provided different information, they found it to be, you know, discrediting, as opposed to this is science. Science evolves.
But before he talks, and I do want him to talk, I've had my hand up and I realize you can't see me. So go ahead, Phil, and then just make sure you come back to me. I have a couple comments.
Absolutely.
Sure. So we did something similar to CDC. We tried at the end of each time we did an interview or did some kind of a comment that it was a rapidly changing, rapidly evolving situation, that the science was moving very quickly. So that what might be true today might be changing next week. So people got used to it here, but you know, people still tend to focus on that one negative thing that they wanted to pick up, and they would try to throw that in your face all the time.
So you, in other words, you kind of prep them the fact that things are going to change. Here's what we know. And, you know, so that you could then point back if anybody said, well, you know, you said this on this day. And, you know, yes, we said this, but we also said that this is what we know today.
Correct. We kept trying to keep in the back of people's minds that the science was rapidly evolving and that things were going to change. It wasn't going to be the same.
Got it. All right, Sue, apologize. Go ahead, please.
That's fine. So I have two comments. The first one builds off of something that I say over and over again. We have a challenge in all of this, in that when public health and public health communication works, it's invisible. Things don't happen. So H1N1 reminded me of being at an airport, and I was checking in and my ticket said doctor, and the woman at the gate said, what kind of doctor? And I said public health, and she kind of did a raspberry and said, oh, public health, yeah, that flu epidemic. And I said to her, so how do you cough? You know, she went like this. And what's that on the counter? Hand sanitizer. So you actually got the message. You know, you were safe. And so the flu didn't happen. That's public health. So, you know, some of the problem is that, you know, you have to tell people to do things that if they do, they don't see a problem. But the second thing that I also wanted to mention was, and this is in addition to, not instead of, but I did mention that through the National Academies of Science, Engineering, and Medicine, there were efforts during the COVID epidemic to create rapid expert consultations to do just-in-time answering of critical questions. Some of those questions came from the White House Office of Science, Technology, and Policy, but more importantly, the Academies launched an effort to create these rapid expert consultations with state and local health departments in mind. What kinds of questions would they have, and what would be helpful communications for them. So just quick example, we did one on what constitutes good data and how do you get it and so on and so forth. I mean, clearly our colleagues, here are far beyond where they may be in a rural health department in the state of Iowa, no offense to the state of Iowa. So, and those are all available online, and it, just suggests to me that maybe the reach of that, I know we tried to we partnered with NACCHO and other things, but I do think there are ways of bringing in organizations like National Academies and other organizations that do this on a regular basis and have the infrastructure in place to make it available nationwide or even worldwide.
Thank you. One more question, Phil. So obviously your agency did not do this alone. And so I ask what kind of support did you have from Mayor Holt of the Oklahoma City and any other local county agencies that may have joined you in either amplifying or reaching their particular stakeholders with similar messaging?
Glad you asked that. It's a good closing point. So we had great support from our local elected officials. And I'll be honest, they were more interested in our local information and local data than they were from what was coming out, from the national perspective. Because we would go to these city council meetings and they would say, that's interesting. What's going on here and what can we do? Because they did trust us. We had exceptional trust here at our local level. So yes, they did help us amplify our messaging. We also had some pretty good help from our College of Public Health here in Oklahoma. So they were very good at working with us on some of the information that we needed to do and specifically working on some of the research that we needed to do. We spent an hour or two every morning trying to debunk studies that were coming out. So I would have loved it if we'd had access to Tricia's thing at that time. That would have been very helpful.
And while you still have the mic, I would just ask you to provide any final remarks on lessons learned for future management of infodemics.
Again, I think communications can't be an afterthought anymore. We're only as effective as what we can get out to the public and as much as they trust us with the messaging. So that's my message. Do what you can. You're going to have to probably put a little bit more of your budget into your communications, because if you don't, what you're doing really doesn't have that much meaning anymore. It has to be effective.
I would ask the same question to Tricia and Sue. Tricia, you first.
Yeah, just to piggyback on what Phil said, I think communication is really key moving forward. We have a lot of expertise and we can hopefully build on these collaborations now that we know different groups doing similar work. Hopefully we can utilize these AI tools and again, the expertise to build these frameworks for the future. I don't want to say future pandemic, but future public health emergencies. So I think everybody just staying in communication and working together, I think we can build a great path forward.
And Sue, final word?
3 quick points. Do it now. Set up the infrastructure. Don't wait. I think we need to be mindful that there are elements of our population who are in chronic public health emergencies. So, we shouldn't just kind of sit back and pretend we don't have any. And the third is, collaborate across sectors and make these private sectors more accountable for helping to solve the problem than simple 5-line code of AI algorithm. We can't artificially intelligence our way out of this.
Yeah. And just, personally, I would say as somebody who has worked in public health communications at the state and federal level for many, many years on many public health emergencies, clearly the paradigm has shifted. And as a communicator, I'm interested in seeing what the future holds, because I think there's a whole new landscape of how we do public health communications, and I look forward to taking the information that was shared today and has been shared over the last day and a half already, and seeing where we go with it. So I just want to thank the panel for their time and for their really important work. And I will turn the moderation over to the next panel on community engagement and trust building activities. And that's going to be moderated by Jewel Mullins. So Jewel, take it from here.